Welcome to Biology Minds. Today we're going to talk about the heart. So as we move on through the cardiovascular system, we talked about the blood. Now we're going to talk about the heart, and then we'll move on to the vessels. But before we get to the vessels, we're going to talk about the heart and the role that it plays in the cardiovascular system, in the circulatory system. So there are two different areas where the blood is going to move. We call them the pulmonary circuit and the systemic circuit. Typically, people think about blood flowing through your body as being the systemic circuit, but there is also the pulmonary circuit, which is going to go through the lungs. So as much as we need the blood to circulate throughout the body, we also need that blood to go through the pulmonary circuit so that it can be reoxygenated and we can remove the carbon dioxide from that blood. Keep in mind, we need that oxygen for cellular respiration. So we're going to get that blood to the tissues, and the tissues are going to use that oxygen for cellular respiration, for making energy, and it's going to have a byproduct of carbon dioxide that we're going to have to get rid of. So in doing that, we need the systemic circuit to pump that blood, that oxygenated blood, around, and we need that pulmonary circuit to reoxygenate that deoxygenated blood. There are three types of blood vessels that we'll get more into in the next chapter, but just understand that we have arteries, which are going to carry blood away from the heart. Typically, people think about arteries as being vessels that are going to carry oxygen-rich blood, but in reality, there are some vessels that are called arteries that do not carry oxygen-rich blood, and they are called arteries because what they are doing is carrying blood away from the heart. Then you have veins, which are going to carry blood to the heart. Okay, typically thought about as being deoxygenated blood in there, but it's not named after that because some of the vessels that are called veins do carry oxygen-rich blood. So it's really based on, is this vessel carrying blood away from the heart or towards the heart? And then we have the capillaries, which are the networks between the arteries and the veins, where the exchange of the blood and the oxygen is going to take place so that we can drop off the oxygen, pick up the carbon dioxide, and send it to the veins, where the veins will bring it back to the heart and then to the pulmonary circuit. Capillaries, that's where the exchange takes place between the blood and the tissues, and it's going to exchange the gases that we talk about, the oxygen, the carbon dioxide, as well as the nutrients and any waste products that we want to get rid of. So this is a basic diagram where we have the heart, and we like to look at the heart as having four chambers. So we are going to have our right atria. Remember, this is going to be our right atria because it is based on the patient. So this is the patient's right, and this is the patient's left. And the right atria is going to take in oxygen, poor blood from the systemic circuit, and then it is going to send it to the right ventricle. Okay, and the right ventricle is going to pump it through the pulmonary circuit. So at this point, it goes to the pulmonary circuit, and it reoxygenates, and then it's going to come in through the left ventricle. Left atria, and then it is going to pump it to the left ventricle, and then the left ventricle is going to pump it up through the aorta, and then from the aorta is going to go to the systemic circuit. So the systemic circuit is going to the rest of the body. Remember, pulmonary circuit is going to the lungs, systemic circuit is going to the rest of the body. Like I said, you have that right atrium, which is going to go, the blood is going to flow from that right atrium to that right ventricle. From the right ventricle, it's going to go to that pulmonary circuit. Coming back through that pulmonary circuit, you're going to have the blood go to the left atrium, and from the left atrium, it's going to go to the left ventricle, and then it is going to be pumped to the systemic circuit. All right. When we look at the vessel that is carrying the blood from the right ventricle, it is going away from the heart, so we are going to call it an artery, but it is still oxygen poor blood. So from there is going to be oxygen poor in the pulmonary artery. All right, or arteries, I should say. So in these pulmonary arteries, they're going to see oxygen poor blood. So this is where I talk about how Typically, people think about arteries having oxygen-rich blood and veins having oxygen-poor blood, but really we see that the exception to the rule are these pulmonary arteries and the pulmonary veins. Then it is going to be reoxygenated through the lungs, so it's going to hit the lungs. All right, it is going to become oxygen-rich, and then it is going to go to the pulmonary veins. All right, and now it is going to be oxygen rich going into these pulmonary veins, and the pulmonary veins are going to bring it back to this left atrium, and now it is oxygen rich, and it is going to send it to this left ventricle, which is very muscular, and that is going to really be the powerhouse to pushing that blood throughout the body through that systemic circuit. The heart has veins and arteries of its own. The tip of it, even though it's the bottom of it, we call it the apex. So if you're looking at a triangle, you would call this the apex. But the heart is somewhat kind of like an upside down triangle, and this is the apex. So we call that bottom part, that pointy tip, the apex, and we actually call the top of it the base. So it seems kind of weird to say it like that, but if you were thinking about it like this triangle right here, it would make a little bit more sense. So it's an upside down triangle surrounded by a pericardial sac. This pericardial sac is going to help it move freely and continue to pump within that chest cavity. Sits between the two pleural cavities in this mediastinum. So it has this cavity that it sits in. We see that the lungs are on each side. We have this this superior vena cava returning, and we have this giant aorta leaving the left ventricle. The pericardium is a double lining of the pericardial cavity. You have the visceral, which is the inner layer of the pericardium, and then you have the parietal layer, which is the outer layer. So the parietal pericardium is the outer part, and it forms the inner layer of the pericardial sac. The pericardial cavity is between the parietal and the visceral layers, and it contains this fluid, pericardial fluid, and that allows it to for the heart to really move freely so that it can continue to pump and not have any friction. The pericardial sac is a fibrous connective tissue, and it surrounds and stabilizes that heart. If we look at the external anterior surface, so this is the front part of the heart, we see that we have the outside right atrium that we call this auricle, and we have the right ventricle, and then on this side you'd have your left ventricle and your left atrium. Here we see the superior vena cava. On the other side, going up into here, we would have our inferior vena cava. We also have this pulmonary artery right here. It is colored blue because remember that is going to be, even though it's called an artery, it's going to carry oxygen poor blood. And then we have this giant aorta here, which is going to send oxygen, send oxygen and blood through the systemic circuit, through the rest of the body. On the backside of the posterior surface, you have this right atrium, which is going to get blood from both the inferior vena cava and the superior vena cava, and then it is going to go through the heart, go to the pulmonary circuit, return back to the heart, and then be pumped out through this aorta, where it's going to go to the rest of the body. The heart wall, it has this this outer epicardium, the middle myocardium, and then the inner endocardium. The epicardium is that outer layer, myocardium is the middle, and then the endocardium is the inner layer. When we look at cardiac muscle tissue, so we looked at the three different types of muscle tissue where we had skeletal muscle tissue, and we had smooth muscle tissue, and we had cardiac muscle tissue. Remember that cardiac muscle tissue looked a lot like skeletal muscle tissue, but it had these intercalated discs. Okay, these discs helped it to continue to function on its own, autonomously. So in the right atrium, we have some things that we look at where we have this foramen ovale or ovale. Before we are born, we have this opening. Since the lungs aren't working and you're getting this oxygen from the umbilical cord from the mother, we see that the two atria, the left and the right atrium, are going to have a hole in it, which is this foramen, and that's going to allow that blood to flow between the two, so that really we can pump that oxygen-rich blood throughout the body. But then after birth, it's going to seal off, and that then leaves a little marker that we call the fossa ovalis. Here we see a cross section of the heart, and we need to know the different parts of this, the inside of the heart. So while all the blood from the systemic circuit is going to come in from the superior and the inferior vena cava, it's going to go into this right atrium. Okay, once it goes through there, then we are going to see that it goes through. There's a valve that separates the right atrium from the right ventricle, and that is called the tricuspid valve. All right, tricuspid is because it has three little leaflets, which we'll see in a moment, and it is going to go to the right ventricle. The right ventricle is going to then send it to the pulmonary circuit through that pulmonary artery, and we see that this is one leaf, this is another leaflet, and this is a third leaflet, so we call it a tricuspid valve. If you ever mix up the two valves, atrioventricular valves as we call them, or we call them AV valves, you can remember that tri has an R in it, so that is the right side. Holding on to these, responsible for opening and closing these leaflets or these valves are these chordae tendineae. So those are your heartstrings. If you ever hear anyone saying that you're tugging on their heartstrings, all right, that's what they're referring to. That's the chordae tendineae, and that is what is going to open and close these valves to allow for the chambers to fill up, and then for the chambers then to empty. Then from there, you are going to see that we have valves also here. This is going to be the pulmonary valve, and then it is going to go through the pulmonary arteries to the lungs, back through the pulmonary veins into the left atrium. The left atrium has its own atrioventricular or AV valve called the mitral valve, sometimes called the bicuspid valve. Bicuspid, mitral, same thing. And that is going to be responsible for opening and closing between the left atrium and the left ventricle. We see that the left ventricle is very muscular. This area is very muscular because it needs to be strong enough in order to push all that blood to the rest of the body through that systemic circuit. It is then going to go through the giant aorta, through the aortic arch, and then is going to branch off into other arteries, and then eventually arterioles, and then to the capillaries, and then make its way back through the ventrioles, and then through the veins. So it's important to know these steps, how it goes from the inferior and superior vena cava into the right atrium, makes its way around to this, then eventually ends up at the systemic circuit, and then is going to make its way back through to that inferior and superior vena cava to start all over again. This is a diagram that's going to show you the difference between how muscular the right and the left ventricles are. If you look at the right ventricle, not nearly as muscular as that left ventricle because it only has to get that blood to the lungs, and then it makes its way back, where the left ventricle is going to have to get that blood through the entire body, through that entire systemic circuit. The heart itself has vessels of its own. So if you look at the heart, not only is it supplying the entire body with the oxygen and the blood, it's supplying itself with the oxygen and blood. So these are coronary vessels, coronary arteries, coronary veins that we also are going to look more into as we move on. This is going to be the posterior surface, showing you how vascular that the heart is. When people are having a heart attack, they're going to have a blockage in one of these vessels, and the heart is not going to get enough oxygen. It's not going to get enough blood to itself in order for it to continue to function properly, and that's where we run into major issues. So some of the major diseases that we talk about in anatomy and physiology are coronary artery disease, sometimes called heart disease. They nowadays they've abbreviated it for as CAD. But it's areas of partial or even complete blockage of coronary circulation. So cardiac muscles, cells need a constant supply of these oxygen nutrients, there's going to be a reduction in this blood flow and in the oxygen, and it's going to cause health problems, and doctors are going to have to go in and do surgery and open up those vessels for people. So usually causes formation of fatty deposits or atherosclerotic plaque, atherosclerosis that we've talked about previously in the wall of coronary vessels, and the plaque, or sometimes a moving plaque, which is a clot or a thrombus, then narrows that passageway and reduces the blood flow, and it can further decrease or stop blood flow if we see spasms in smooth muscles of the vessel wall. One of the first symptoms of CAD is angina pectoris, which is chest pain. Okay, so people that have chest pain, all right, that's not a good thing. Common form of if temporary ischemia develops when the workload of the heart increases. Although individuals may feel comfortable at rest, exertion or emotional stress can produce pressure, feeling of chest constriction, and pain that may radiate from the sternal or the breastplate area to the arms, back, and the neck. So if people are complaining of this, all right, this might be an early indication of the fact that they have heart disease and they have coronary artery disease, and there's an issue with their heart vessels. Myocardial infarction is the anatomical or the medical term for heart attack. So part of the coronary circulation becomes blocked, and the cardiac muscle cells die from lack of oxygen. So, the heart is starting to die when someone is having a heart attack, and the death of affected tissue creates a non-functional area known as an infarct. All right, so that's where we get this infarction from. The myocardial tissue is becoming infarcted. There is an infarction of the myocardial tissue, and heart attacks most commonly result from severe coronary artery disease. So you have coronary artery disease, that's going to lead to a heart attack. Some consequences, it occurs near the start of one of the coronary arteries, the damage will be widespread and the heart may stop beating. If the blockage involves one of the smaller arterial branches, the person is going to survive the immediate crisis, but it may have complications such as reduced contractility and cardiac arrhythmia. So you're going to have further heart problems. A crisis often develops as a result of a thrombus or a clot formation at a plaque, and which is a condition called coronary thrombosis. Vessel already narrowed by the plaque formation may also become blocked by a sudden spasm in the smooth muscles of the vascular wall. Individuals having myocardial infarction or a heart attack experience intense pain, similar to what's felt in angina, where you feel that pressure on your chest. A lot of people will say that it feels like I have like an elephant sitting on my chest, and I can breathe, but it's very difficult to really get past that pain. And we see that sometimes people have different symptoms. Pain does not always accompany the heart attack, so the condition can go undiagnosed and may not be treated before someone has a fatal heart attack. Usually it's going to be diagnosed with an ECG, often called EKG, where they're going to look at the electrical activity in the heart, as well as blood studies. So they're going to take your blood, and they're going to look for these enzymes that are seen in people that have heart attacks. They're going to look for this cardiac troponin T and cardiac troponin I, which is as well as a special form of creatinine phosphokinase, which is called CKMB. So when they look at your blood work, they're going to know right away, hey, the EKG showed us that there is positive for heart attack, but we also look at the blood work, and the blood work says that they have this troponin T or troponin I, or they have the CKMB in it, and that is a direct indication that this person had a heart attack, and we have to treat them accordingly from here on out. So about 25% of heart attack patients die before obtaining any medical assistance. 65% of heart attack deaths among those are under the age of 50, occur within an hour after the initial infarction. So people have a heart attack, and you better get it treated immediately. You got to get right to that hospital. Treatment of coronary artery disease and heart attack. You want to modify their lifestyle, stop smoking, make sure they're treated for high blood pressure. There are a lot of medications out there that can help with that. Dietary modifications to lower cholesterol and promote weight loss, as well as reducing stress, which is not as easy for a lot of people. But also, you're going to want to increase physical activity. You don't want to have people go out if they're completely overweight and they're very unhealthy and they're out of shape. You don't want them to go run, start running 4 miles a day every day. But if they never walk, and they just sit at home and they're eating potato chips every day, then you want them to start getting out there and maybe start walking and work their way up to more physical activity and an exercise regimen. Some other treatments as well. When we talk about drugs, you want drugs that are going to reduce any coagulation so that there's not that risk of thrombosis or that clot, such as aspirin and Coumadin. Drugs that block sympathetic stimulation, such as propranolol and metoprolol. Drugs that cause vasodilation, such as nitroglycerin. Drugs that block calcium movement in the cardiac and vascular smooth muscle cells, which are called calcium channel blockers in a heart attack. Drugs to relieve pain, fibrolytic agents to help dissolve clots, and oxygen. So non-invasive surgeries are going to be atherectomy, which is a blockage by a single or soft plaque, may be reduced with the aid of a long, slender catheter. So they insert a catheter into that artery, and they're going to help to relieve that blockage. They also have balloon angioplasty, where they put that catheter into that vessel, and they're going to inflate a balloon, and the balloon actually pushes on that plaque and helps to open it up. Now, the plaque is still there, but it's going to help to open up that vessel a little bit more. Then you also have coronary artery bypass graft, or sometimes they call it a cabbage. A lot of times they'll call it a cabbage because they don't want to say coronary artery bypass graft every time. But just small section is removed from either a small artery or a peripheral vein and is used to create a detour around the obstructed portion of the coronary artery disease. So if this vein right here, or this artery, is going to be blocked off, what they're going to do is they're going to take maybe an artery from your thigh, and they're going to create this area for the blood to now flow around this blockage area. And then when we talk about cardiac physiology, there's two types of cardiac muscle cells. You have the conducting system and you have the contractile cells. Cardiac cycle begins with an action potential at the pacemaker called the SA node, transmitted through the conductive system, produces action potentials in the cardiac muscle cells. So just like we talked about action potentials in muscle cells and we talked about them in the nervous system, right, it's also important in the cardiac cycle. So we are going to measure these and look at these using an EKG or an ECG electrocardiogram, which shows the electrical events in the cardiac cycle. The conducting system, a system of specialized cardiac muscles, it initiates and distributes the electrical impulses through that stimulate the contraction. So it has its own kind of flow to it, so it does it on its own. We call that automaticity, and the cardiac muscle tissue contracts automatically. That's what that means. So you have the SA node in the right atrium. Then you have the AV node, which is a junction between the atria and the ventricles. And then you have the conducting cells throughout the myocardium. These conducting cells, interconnect the SA node and the AV nodes, and they distribute the stimulus through the myocardium. Pro-potential, also called pacemaker potential, that resting potential of conducting cells gradually depolarizes towards the threshold. We see that it starts up here. We have our SA node. It's going to then send it down to the AV node, and it is going to communicate with this bundle branch, which is going to send it to these Purkinje fibers. And this is what's orchestrating the contraction of the heart, that beating of the heart. So the SA node generates 80 to 100 action potentials per minute, and that parasympathetic, so we talked about that parasympathetic influence from the brain, right, from that cerebellum and that medulla oblongata. We have it's going to slow the heart rate. So The AV node generates about 40 to 60 action potentials per minute. That is why the medulla oblongata is so important, because of that parasympathetic influence on the heart rate. So the SA node is going to be in the right atrium. It's called the pacemaker because it sets the pace for the heart, and it connects to the AV node. So first, if we break it down in steps, we have the SA node activity and atrial activation begins, so that the top two chambers are going to begin contracting. And then you have the AV node, where we see in step 2 the stimulus spreads across the atrial surfaces and reaches the AV node. And then there is a 100 millisecond delay at the AV node, and atrial contractions begin. So it's those atrial contractions are all started by the SA node, which is going to go to the AV node, and then the AV bundle, we see the impulses travel along the interventricular septum within the AV bundle, and the bundle branches to the Purkinje fibers and by the moderator band. So these papillary muscles are then signals for them to contract. So we have the atrium contract, the atria are going to contract, and then we're going to see that the ventricles are going to contract through the impulses that come through those Purkinje fibers. So the impulse is distributed by the Purkinje fiber, and then the ventricles are going to contract. There are different terms that we use, where we have bradycardia, which is a slow heart rate, tachycardia, which is a fast heart rate, and we have an ectopic pacemaker, which is abnormal cells, and they generate high rate of action potentials. EKG, ECG, remember that's recording electrical events in the heart. And then when we look at the EKG or the ECG, there are different waves that we are looking for and we are looking at. When we look at a P wave, this is atrial depolarization, which means that the atria are contracting. When we look at the QRS complex, that is the ventricles depolarizing or contracting, and then the T wave is the ventricles repolarization. So a lot of people say, well, when do the atria repolarize? Well, we don't see it on the EKG in waves because it is happening during this big, huge QRS complex. We also are going to measure how long it takes in between different segments or different waves. So we have the PR interval and the QT interval that we look at. This shows a 12 lead EKG. So there are 12 different spots where this person is connected to the EKG machine. There are also other ones that have 5 leads, and a lot of times they'll use ones that are 3 leads at the hospital, because unless they're doing an EKG, all right, they don't need it to be that precise. They just need to monitor that person. So they'll do the 12 lead real quick to kind of get a baseline, and then they'll hook you up to the 3 lead EKG to watch you for the remainder of the time that you're at the hospital. So if we look at just a normal EKG readout, we see that we have this P wave right here, which is going to be the atrium contracting or depolarizing, and then as that is repolarizing during this area, we see that there is a giant spike where the ventricle is going to depolarize, and then we have this T wave, which is the ventricles repolarizing. So this is what we're looking for. Anything that doesn't quite look like this usually indicates an issue, and we'll talk more about that as we move forward. So keep these things in mind as we move to the other chapters, as we see that we've talked about blood, and we talked about the heart, and we're going to talk about the blood vessels, and as we move on to the respiratory system and the digestive system, how it all really comes together in order to maintain homeostasis.